Hey y'all. I'm looking to see if Lloyd is on and if he wants to say anything before we get started. I don't see him in the list. We'll give it a minute and then we'll just hop in. Well, it's a couple minutes after, so let's go ahead and get started. My name's Lofton Wilson. I was invited by Lloyd to come talk with y'all about harm reduction in general as approach and a philosophy, and then also to go over some overdose prevention training, how to recognize and respond to an opioid overdose, as well as stimulant overdose and our Good Samaritan law and things of that nature. So I will go ahead and jump in. Does anybody know, do we have it until 2:30 or till 2? Either is fine with me.
I believe it's 2:30.
Excellent. Well, I think that will be plenty of time and maybe more time than we need, but we'll go through things. There'll be plenty of time. I'll leave time for questions at the end, but if folks have questions in the meantime, feel free to just unmute yourself and chime in or put it in the chat. And let me see if I think I can share. Let me try. Yep. Beautiful. All right, so I'm Lofton. I work for the North Carolina Harm Reduction Coalition, which is a statewide nonprofit, been around since 2004. And we do a combination of advocacy and direct service around advancing harm reduction in North Carolina. Some of our programs are, we have a statewide overdose prevention program where we distribute naloxone directly to people who are at risk of experiencing or witnessing an overdose. We've been doing that since 2013. We have 7 syringe service programs across the state, from Wilmington on the coast all the way to Haywood in the mountains, including one here in Durham. We work on law enforcement assisted diversion programs, helping communities implement them, including Fayetteville's, which was the first LEAD program in the US South. We do jail-based harm reduction outreach and education in a couple of jurisdictions across the state. We do linkage to care and peer support to help connect people who use drugs to resources and care. A harm reduction phlebotomy program where we do field phlebotomy testing for HIV, Hep C, Hep B, and syphilis. And we have 2 drug user health hubs, one in Wilmington and one in Raleigh, that are certain service programs that also have other on-site wraparound services like a food bank on-site, connections to medication-assisted treatment and hepatitis services and things like that. And then we also do a lot of training, advocacy, and technical assistance with different stakeholders across the state to advance the understanding and implementation of harm reduction interventions in North Carolina. And I work here in Durham at our community-based service program here. And we been operating above ground since 2016. And we operate 3 afternoons a week here in Durham. Mondays we do deliveries, so we'll come to anybody in Durham County who can't come to us in our mobile van. Wednesdays we do street outreach at a couple different locations around downtown Durham, where we've been going regularly for years and folks know to come to us. And then Fridays, we are hosted in the Office of Recovery Community of Durham inside the Elizabeth Street Church. And folks can drop by and access our services there. It's a picture of some of the chaos of the mobile van, which some of y'all are familiar with. So to kind of set set the foundation for what we're talking about today. So I'm sure a lot of y'all are experts in harm reduction and are very familiar with this sort of modality already, but in case anybody is not, just sort of the basics of it. So harm reduction as a way of approaching and managing and mitigating risk is something that we're all pretty familiar with in other areas of our lives already, even if we haven't thought about it as applied to drug use. So for example, driving a car is pretty dangerous, and we're pretty likely at some point in our lives to hurt ourselves or to hurt somebody else when we're driving a car. But as a society, we don't respond to that by saying that nobody can ever drive and nobody can ever build cars, and all car-related activities going to result in incarceration and stigma. Instead, we have seatbelts, we have airbags, we have speed limits, we have, driver's education, we have sort of public education campaigns about things like drinking and driving or texting and driving. We have all these interventions in place to make what is inherently an unsafe activity as safe as possible for everybody involved, for the driver, for the passenger, for the pedestrian, while recognizing that there's risk that can never be removed completely. So that's harm reduction. And harm reduction is really just taking that same common sense type of approach to managing risk and applying it to drug use or to other activities that are criminalized and stigmatized in our society, like sex work. So harm reduction, when it is applied to drug use, is about social inclusion. So thinking about, instead of things like criminalization and stigma, which sort of exclude people who use drugs from the fabric of society, harm reduction is about thinking about bringing people in rather than pushing them away. It requires us to think systemically about sort of the causes of chaotic drug use and substance use disorders more deeply than just individual experiences or choices. It's founded on principles of respect and non-judgment. It understands that a lot of drug-related problems and drug-related harms that we see in our society and our community are the result of failed policies and laws that have been around for a long time. So, they took a while to build up to the state that they're in now, and they're going to take a while to undo. And it's all aimed at reducing the harms associated with drug use. So there's both health harms, social harms, interpersonal harms, things like that. And when we think about implementing harm reduction, there's several levels to it. So there's the individual level where, I as an individual can practice harm reduction in my relationship with drug use. And that can be my relationship with legal or illegal drugs. It can be around my relationship with tobacco or nicotine or alcohol, or it can be my relationship with heroin or methamphetamine or cocaine. You can practice it in any type of drug use. So some examples of individual level harm reduction practices could be, using a sterile syringe every time if you inject, having naloxone on hand, never using alone, thinking about a less risky route of administration, checking your drugs so you have more information about what you're using, doing tester shots, resting, hydrating, eating, using one drug at a time, not mixing. So those are all things that individual people can do while they're using drugs to make their drug use a little bit safer for them and for the people around them. And then examples of harm reduction policies. So I think I missed one, the community level, yeah. So you have the individual level, which is stuff that I as an individual can do, and then things on the community level, like programs which make those individual changes easier. So things like syringe service programs that distribute safer injection supplies, community-based naloxone distribution that helps people be prepared to respond to an overdose while it's happening. Things like overdose prevention centers or safe consumption sites, which some communities have started implementing to have a safe place for people who are using to go and be monitored medically. Medication-assisted treatment or medication for opioid use disorder, things like methadone or buprenorphine. Having non-abstinence-based treatment, counseling, and recovery support available to support people and help them move along the stages of change even if they're not ready for abstinence from drug use. Things like drug user help hubs, post-overdose response programs, and drug checking services are all examples of community level harm reduction programs. And then you can also take it out farther, thinking about sort of the structural level, so the policies and laws that are in place that can make these community level programs, easier or more difficult to operate. So things like Good Samaritan laws that offer protection for people calling 911 and seeking help during an overdose, legalizing harm reduction programs like syringe service programs or overdose prevention centers, putting into place diversion or deflection programs in communities, which help reduce the number of people who are criminalized and caught up in incarceration, and also policies like Ban the Box that help people who are leaving incarceration be, welcomed back into social life. Drug user unions, which are, groups that help people who are directly impacted by drug use have sort of a collective political voice. Housing first policies that focus on making housing available to people regardless of abstinence from drug use. Safe supply, so things like these are, in Canada, there's, I think a couple different places have sort of pilot programs where they're looking at sort of testing out a safe prescribed drug supply. So things like prescription heroin as an alternative to the very contaminated global drug supply. And then, of course, the biggest sort of structural change that we could consider is, decriminalizing drugs. And then looking out sort of more abstractly, we can also think about harm reduction in terms of cultural understandings and attitudes around drug use that we all have. So examples of sort of harm reduction based attitudes are understanding drug use as a continuum. So recognizing that, there's a vast spectrum of experiences around drug use from, on one end, the very harmful, the very chaotic to, on the other end, the very, mundane and non-harmful and non-chaotic, and that there's many, many stages in between. And that while it's, in the same way that it's possible for drug use to go from the less harmful end of the spectrum to the more harmful end of the spectrum, it's also possible for people to reverse that trajectory and to make small positive changes in the other direction. So thinking about the incremental changes that people can make. So we have a saying in harm reduction, any positive change. So recognizing that any sort of step that people take in the direction of meeting their health and wellness goals is great and is something that should be supported and encouraged rather than focusing only on sort of very big changes. Using value neutral language, so trying to use things like drug use instead of drug abuse, just to kind of have a neutral way to talk about experiences. Destigmatizing evidence-based treatments for substance use disorder, so things like medications for opioid use disorder that can still be very stigmatized and misunderstood. Understanding the stages of change, so recognizing that when any sort of big behavioral change that we're struggling to make in our lives is a process, it's not an overnight thing, and it's a process that we go through and that a lot of times we go through in cycles many times in our lives. Shifting from a criminal justice focused response to drug use to a health focused response, understanding the historical role of drug policy in the US and sort of the part that it has played in different social experiences people have of drug use. And meeting people where they're at, which is sort of a core tenet of harm reduction and is about, not placing our values or our expectations or our hopes for people's trajectories onto people and just seeing, where they're at today, what their goals are, what their hopes are, what they find to be positive or negative in their own life. So some of the principles of harm reduction that were sort of crowdsourced and put together by the National Harm Reduction Coalition. So harm reduction accepts, for better or for worse, that licit and illicit drug use is part of our world and chooses to work to minimize its harmful effects rather than simply ignore or condemn them. Harm reduction understands drug use as a complex, multifaceted phenomenon that encompasses a continuum of behaviors from severe abuse to total abstinence, and acknowledges that some ways of using drugs are clearly safer than others. Harm reduction establishes quality of individual and community life and well-being, not necessarily the cessation of all drug use as the criteria for successful interventions and policies, recognizes that the realities of poverty, class, racism, social isolation, past trauma, sex-based discrimination, and other social inequalities affect both people's vulnerability to and our capacity for effectively dealing with drug-related harm. Harm reduction does not attempt to minimize or ignore the real and tragic harm and danger associated with both licit and illicit drug use. Harm reduction calls for the non-judgmental, non-coercive provision of services and resources to people who use drugs and the communities in which they live in order to assist them in reducing attendant harm. Harm reduction ensures that drug users and those with a history of drug use routinely have a real voice in the creation of programs and policies that are designed to serve them. And it affirms drug users themselves as the primary agents of reducing the harms of their drug use and seeks to empower users to share information and support each other in strategies which meet their actual conditions of use. Um,
Lofton.
yes.
Hey, my name is Malcolm White. I work for Alliance Health. I just wanted to, I put a question in the chat and you might not be able to see it, but could you clarify what a tester shot is?
Oh, sure. Yeah, and that's yeah. Thank you for yeah, it's hard to see the chat while I'm in the slide. So yeah, feel free to just jump in. So a tester shot is, for example, if somebody is injecting, instead of injecting the full amount that they are planning to use, you injecting a small amount first just to see what their response to it is and how it feels. This is particularly something that people would do if they have like a new something that is from a new source or looks different or that they have questions about, and they don't want to use their regular amount automatically. So it's a way of just trying a little bit first. So in the same way you could do a tester shot, if you're snorting something, you could snort just a tiny bit first and see how it feels and then gradually add to it, or whatever your route of administration is. The idea is just do a little bit first to see how it feels, to give your body a moment to acclimate, and then make decisions about how much more you want to use after that, rather than using the full amount that you're planning to use right away. So that just helps, reduce the risk of overdose and helps people gauge their drug use a little better. Does that make sense?
Yes, absolutely. I think about it like a sample. I appreciate it.
Yep, absolutely. So I want to talk about syringe service programs, which are sort of a key harm reduction intervention and program. So they've been legal in North Carolina since 2016. We have, I think, somewhere almost 50 maybe registered SSPs across the state now. So they're not in every county and every community. We're very lucky here in Durham. We have two. We have, one that the health department runs, and then the community-based one that NCHRC does. Most communities do not have two. Many communities do not even have one. So we're pretty lucky. So here are some of the things that certain service programs can offer. So sort of, these are programs that used to be called needle exchange programs or syringe exchange programs. Now they're typically called either syringe service programs or syringe access programs. Syringe service programs sort of speaks to the more sort of comprehensive wraparound nature of the services. So that's typically the term that is preferred now. I still a lot of times will say needle exchange, is kind of old fashioned. And so they were originally conceived during the HIV epidemic in the 80s as a way of reducing the spread of HIV via injection drug use. And so they play like a key role in reducing viral infections like HIV and hepatitis C among people who use drugs, and then also reducing like bacterial infections and other types of injection-related harm like endocarditis and myocarditis that can be consequences of not having access to sterile injection equipment. So sort
Can
of
I ask a question?
Go for it.
Was the name changed to become less stigmatizing? Because you said you still use needle exchange. So was that from a stigmatizing point, or was it from a medical point?
I think it was to be more accurate, and also specifically the exchange part is a little bit of a misnomer, because it's not a one-for-one. Like in North Carolina, our law says, programs should provide people with supplies that they need in sufficient quantities so they don't have to share or reuse. And then, we encourage people to either bring the syringes back or teach them how to safely dispose of them in other ways. So it's not like I take in 10 syringes, I get 10 syringes. It's not an exact exchange ratio like that. So it was changed more to be sort of a more accurate reflection, and also having syringe service programs also reflects all these other types of services that these types of programs can offer besides just the injection supplies. So that's my understanding of sort of the evolution of the name, but that's a good question. So these programs can provide sterile syringes and other injection supplies, safe syringe disposal and biohazard containers, naloxone and overdose prevention training, types of drug checking. So that includes distributing fentanyl tests. And then there's also other ways. Some programs have machines on site that people can test their drugs to see what's in them. Many SSPs now are participating in a mail-based drug checking program offered by the UNC Data Lab, where people can mail in small samples and then anonymously check the results online to see everything that's in the sample. Some SSPs offer safer snorting and smoking supplies, wound care and hygiene supplies. Many of them offer peer support, resource navigation, and linkage to care, safer sex supplies, testing on-site for HIV, Hep C, HPV, or syphilis. Many, including our program here in Durham, offer syringe litter pickup services. So if people are noticing an area in the community that has syringe litter, they can reach out and then people from the SSP who have like training and equipment to pick up syringes safely can come clean up the area, and then, try to work with community members to figure out solutions to the problem if it's an ongoing thing. Lots of SSPs have sort of adapted to doing COVID-specific harm reduction, so distributing masks, doing vaccine outreach, and other sort of COVID-specific stuff. Many also have food resources available for participants. Some organize harm reduction-based support groups or advocacy groups for participants. And some SSPs also collaborate to offer other kind of harm reduction programming in the community, such as post-overdose response or LEAD or jail outreach or support. So here in North Carolina, we have legal protections for people who work at or volunteer at or participate in SSPs. So the law, which was passed in 2016, says that participants can't be prosecuted for injection-related supplies obtained from or returned to an SSP. So that's the syringes themselves, any residue in them, which makes it safer for people to collect and return used syringes. And that also applies to any of the other injection-related supplies that are distributed or returned. So in order to sort of claim this immunity, you have to have written verification that you're a participant. So that usually takes the form of a participant identification card that looks something like this. This is an example of our card, but most cards will have some version of this. They'll have the information about the statute and then like a unique identifier that's derived from demographic information and usually not the person's actual name. So here's a little bit more detail about the types of supplies and services that are offered. So syringes, programs typically have several different types of syringes available for folks for IV use, longs and shorts. People typically know what works best for them and will minimize, their vein damage. Programs can also offer types of syringes that are appropriate not just for intravenous use, but for subcutaneous or intramuscular use. So that's helpful for people who are using syringes for things like steroids or hormones. We also distribute tons of sharps containers of different sizes. So those can go all the way from, little quart-sized ones that are a good size to have like in a backpack or a vehicle to larger, like 2, 3, or even like, 6 or 8 gallon ones that are appropriate to have in a home. The injection supplies. So everything, basically the standard is supplying everything that you need for every step in the injection process so that you can have sterile items for each step in the injection process, because preparing and injecting drugs involves a number of steps and a number of different types of equipment. And each stage of the process, there's opportunity to have either, a less safe or a more safe way of doing it. So the idea is providing supplies and education so people can take each step of the process in the safest way possible and reduce their risk of getting or giving a viral infection like HIV or hepatitis C, as well as getting bacterial infections from reusing supplies or using unclean supplies, unsterile supplies. So things like the cooker, which you prepare your solution in, the cottons, which are the filter you dry your solution up through, tourniquets, which help identify veins, alcohol pads to clean your skin prior to injection, sterile waters, which are really important, especially for folks who are unsheltered and may not have consistent access to running water, vitamin C, which is basically an acidic agent that you need if you're injecting something that needs to be broken down into an injectable form. So something like black tar heroin or crack cocaine that's in a smokable form, it needs something acidic to break it down into an injectable form. And vitamin C is a safer alternative to using something like vinegar or lemonade that's more damaging to the veins. Overdose prevention supplies. So all SSPs in North Carolina distribute naloxone. Typically, it's either the intramuscular version or the nasal version, and we're going to talk through using that in just a little bit here. Drug checking supplies, like I mentioned, fentanyl test strips. Those are tests that folks can take and have on hand. They can check drugs to see if there's fentanyl in them. They're a little bit limited in their utility because they just say yes or no, there's fentanyl in the drug, not how much there is or how potent it is, or what analog of fentanyl it is. But they're very helpful, especially for folks who are using something like a stimulant or a benzodiazepine that they're not anticipating there would be any fentanyl in, but increasingly has become cross-contaminated and can contain fentanyl. So those are very helpful harm reduction tools, especially for that situation. Wound care supplies are a major need that a lot of SSPs help folks with sort of managing and taking care of wounds. So basic stuff like gauze, medical tape, triple antibiotic ointment, hot compresses for dealing with abscesses, Band-Aids, things like that. So some SSPs distribute supplies for safer smoking and snorting. So basically any drug that you inject, you could also smoke it or snort it. And it is much, much safer to smoke or snort any drug than to inject it. So smoking and snorting reduces both your risk of overdose and your risk of, getting or giving transmissible diseases or bacterial infections or things like that. So smoking and snorting in and of themselves are harm reduction strategies. So some of the supplies that programs could pass out are things like pipe covers that you can put on the end of a pipe. So if you're sharing or passing a pipe, you're not accidentally, passing, for example, if somebody has a cut lip, passing blood from person to person on the pipe also protects, you from getting cracks or sores or blisters on your lip from the pipe being hot. The filter that goes in a crack pipe, which needs to be changed out frequently so that you don't inhale microfibers. Sterile supplies for snorting, so things like straws that are different colors, so you know which straw is yours. Encourage people not to share straws. Foil for smoking fentanyl is another big supply item that helps people reduce their risk of overdose by transitioning from injecting to smoking. Safer sex supplies and some basic reproductive health supplies like pregnancy tests or Plan B are really helpful for all participants, but especially for folks who are doing street-based sex work and might not otherwise have access to these types of materials. So at our SSP, we distribute both external condoms, internal condoms, dental dams, lube, and we have pregnancy tests available for folks and Plan B when we get it donated, which is always good to have. Basic hygiene supplies and COVID prevention supplies like masks and hand sanitizer, snacks for folks, just, menstrual supplies, dental supplies, things like that are really helpful for people, especially when they're unsheltered. And SSPs also provide a lot of education and a lot of resources. So that's both education about safer drug use, so things like overdose prevention, safer injection tips, wound care, things like that. And then also connections to resources for, healthcare, treatment, housing, whatever the needs are that people have. We have a couple of really good comprehensive local resource guides. We have the Durham County resources for people who use substances, which the folks, many of you, I'm sure, on the call were involved in putting together. That's very helpful. There's also a regional guide that DHHS puts out called the North Carolina Drug User Guide that's broken apart by some sort of a regional scheme, but they have, MAT providers, inpatient treatment providers, hepatitis C treatment providers, housing, healthcare, food resources, all of that. That's another helpful resource to have for folks. Okay, so that is going over all the certain service program stuff. Before we jump into talking about recognizing and reversing an overdose, does anybody have any questions about the stuff we've covered so far?
I have two questions. Can you specify exactly the details of the North Carolina Good Samaritan law? My question for that is twofold. Is it set up in a way in which, say, a pedestrian non-drug user just happens to see somebody in the event of an overdose, they call? I would imagine that they could potentially get charged for calling the law and asking them to, provide EMS services. So I guess my question really for that specifically is how that law is set up. Say if two people are using actively, one person overdoses, the person in possession of narcotics with the person that overdosed calls 911 and they come out. Is that how that law is set up and established, so that if somebody that's using with the other person calls, they won't face no criminal charges?
Yes, so I'm glad you asked that. So basically the way our Good Samaritan law is set up in North Carolina is that it protects those two people, the caller and the victim. And so it recognizes in the way that it's set up that the real first responders and the people who are most likely to be able to seek help in that situation are often people who are also using together with the person who overdosed, right? So that's who we're trying to encourage to feel safe to call. So that's the intent of the law. So the law says that if I'm with somebody who overdoses, any type of overdose, not opioid specific, if I'm with somebody who overdoses and I call for help and I give my legal name to the operator, both me as the person who calls for help and the person who's experiencing the overdose have immunity from prosecution for certain things. So that's small amounts of most drugs, drug paraphernalia, underage alcohol consumption, if that's an element of the situation, and parole and probation violations that might come as a result of any of those things. So it only protects those two people, the caller and the victim, not any other bystanders, even if they're also rendering aid. It does not specifically protect for arrest, it just protects for prosecution. And it only covers those specific things. So if you have amounts larger than, say, a gram of cocaine or heroin, that doesn't protect for that. It also, because of the weird way that drugs are scheduled, doesn't cover some specific drugs that it really should. So it doesn't, for example, cover fentanyl or methamphetamine. So there's actually like a movement right now, an advocacy movement that's led by parents who've lost loved ones to overdose, trying to improve our law and add some increased protections to make it more meaningful and to make it sort of match the typical laws that other types of states have around this kind of stuff. Does that answer your question? And I also see Rita has your hand up too.
It does. Thank you very much for that.
You're very welcome. And this on the screen is like a very explicit handout of different things that it covers and doesn't cover.
Will
Rita,
there
go
be, I'm sorry, will there be access to these slides after this is over? Or,
Yeah, I'll make sure Lloyd sends them out. Yeah,
okay, thank you very much.
you're very welcome.
So I have a question.
Yes.
So, so you're saying that, and there was something in the news recently about the person being charged because they had the drugs. And so if I'm using drugs with someone and they overdose and I call the police, so you're saying that because I have drugs in my possession, that I would not be charged for that because I tried to call to save the other person's life. Is that correct?
That is correct. If it meets the stipulations in the law, which are like very specific. So that means like if you have less than a gram of cocaine or heroin, if you have less than an ounce and a half of marijuana, you're protected from prosecution for that. If you have larger amounts than those that are covered, or if you have other substances that are not specifically listed in the law, you could still be charged for possession for those things.
Okay, I just have one other question.
Yeah.
So those kits that you were showing earlier, I'm a community person. I know several people on this call, but I'm the type of person that works after hours. So like I feed a group of people that are in Durham off of Fayetteville Street. And so sometimes late in the evening, they'll ask me for Narcan. So how can I get those kits when the harm reduction people are not out on their scheduled days to hand out when I hand out their food? Or is that not something that I am allowed to do? Because I don't really have any, well, I'm from North Carolina AIDS Action Network also.
Yeah.
So I'm just asking out of curiosity.
You could definitely pick up some kits from the health department to have for yourself. If you're distributing a large amount, you would want to be sort of associated with an organization that has a standing order to distribute. But if you're just picking up, you know, a couple for yourself and then you might pass them along to somebody, that's totally fine for you just to pick them up as an individual from the health department.
Okay, thank you.
You're very welcome.
Ma'am, so to the last speaker, in regards to that, I'm the house manager here at Jubilee Home. We're located right off of Umstead and Dawkins on Fayetteville Street. We also serve community members, and a lot of people out here in this area know and respect the house. The house typically shuts down at 11 p.m. But in the event, if you happen to know of somebody that's actively seeking Narcan, naloxone, whether it be injectable or nasal, we do have that and provide that here to community members. Just networking a little bit from one person
So
to another.
what is your name? Because I'll come by and introduce myself so that you'll be familiar with me. You probably see my little gray car drive by there a lot of times.
Yes, ma'am. My name is Michael Ebbs. I'm the house manager here at Jubilee Home.
Okay, thank you.
We're
404
located
East
at
Umstead,
404.
Jubilee.
Yep. Yeah. I see Lofton out there all the time.
I'll see you tomorrow.
Okay,
Yes,
thank you.
ma'am. You're very welcome.
Good connections. That's very good. So let's talk through responding to an opioid overdose, recognizing it, and then using naloxone to reverse it. So I'm gonna I think I'm going to pause the share so I can show. There we go, so that y'all can see me better and I can show the items that I have. So I'll show you how to use both the nasal and the intramuscular version. So naloxone is the generic name, Narcan is the brand name. It's all the same medication. A lot of people just say Narcan because it's easier to say, but naloxone covers all the formulations of it, not just the branded nasal spray. It's been around since 1971. It's been the standard treatment for suspected opioid overdose in, hospital emergency rooms and ambulances for many decades. And over the past couple of decades, there's been a movement across the US to change the laws in states to make community access to naloxone better. So to make it possible for regular people to have it on hand in case, I'm at risk of an overdose or I have someone near me at risk of an overdose, the same way you would have an EpiPen in case if you're at risk of an allergy attack. So here in North Carolina, we've had one of those naloxone access laws since 2013. The law says that anybody in the state can administer naloxone in good faith to somebody who they think is overdosing, and you have full civil and criminal protection. The law also makes it easier for regular people to get naloxone, so it allows for that standing order distribution. So before this law passed, if I wanted, to have naloxone on hand for myself, I would have to go to a doctor and, get a prescription with my name on it and fill it at a pharmacy and pay for it and all of that. So the standing order distribution allows for a doctor to write a standing order for organizations to distribute under. So local health departments or community-based organizations like ours can distribute directly out into the community to anybody who meets our distribution criteria, and people don't have to have an individual prescription. There's also a standing order for all of the participating pharmacies in North Carolina. So any pharmacy can participate in it. And that means that you can just walk into a pharmacy and directly buy naloxone without an individual prescription. So it's not over the counter. You can't just, grab it off the shelf. You have to go talk to the pharmacist and they have to stock it and fill it. But you don't need to have that prescription with your name on it. You can just walk up to them and say, I would like naloxone, and then pay for it either directly or through your insurance. And Medicaid does have on its formulary both the regular intramuscular generic naloxone and the nasal spray Narcan. So your regular Medicaid prescription copay, you can get naloxone at the pharmacy without an individual prescription. So access is much, much better than it used to be. So when it's administered, in the ambulance or the hospital, it's usually like an IV or a nasal spray. When it's administered out in the community, it's either an intramuscular kit that looks like this, that has intramuscular vials in it, or a nasal spray that looks like this. So what you want to look for, if you're with somebody and you're worried that they could be overdosing, if you can't get them to respond when you shake them or call their name, the first thing you want to do is try a sternum rub. So just take your knuckles and rub really hard on their sternum bone right here on their chest. If you do that lightly to yourself, it does not feel good. If you do it as hard as you can to somebody, it really hurts a lot, but it's not going to injure the person. So it's basically just an easy, safe way to test, is the person, just really out of it and a heavy nod, sleeping, or are they really not able to respond? So if they don't respond to something painful like the sternum rub, you want to go ahead and act immediately and get them the things that they need to survive that. So what is happening in opioid overdose is basically, opioids, and those are, pharmaceutical opioids like Oxycontin, Percocet, Dilaudid, morphine, illicit opioids like heroin or illicitly manufactured fentanyl. They all work in our brain the same way. And basically what they do is they attach to the opioid receptors, they give us pain relief, they give us euphoria, they give us, all the great things that we invented opioids to give us. But then what can happen is if you get a certain saturation of them over your brain receptors, they basically trick your brain into thinking that you don't have to breathe. So your breathing slows and then stops. So that is what kills somebody in an opioid overdose, is not being able to breathe, their respiratory system being depressed. And all that the naloxone does is it gets in there and it has a stronger affinity, a stronger attraction to those same brain receptors. So it gets in there and it temporarily swipes all the opioids off of the brain receptors and it covers the brain receptors. So it reverses that process of respiratory depression while it's happening and allows the person to breathe again. So it is really kind of like a magical antidote that we have access to. And it is very safe. So all that it does is attach to those opioid receptors. So if you give naloxone to somebody thinking they might be overdosing, but it turns out something else is happening, like they're having a heart attack or a stroke or something, the naloxone will not do anything to harm them. So the only thing that it does is attach to the opioid receptors. If you don't have any opioids in your system and somebody gives you naloxone, nothing will happen. So it's very safe. That's one of the reasons why it's legal for regular Joes like us to have it and administer it and not worry about hurting people. So you're with the person, you're worried about them, they're not responding to the sternum rub. You want to go ahead and move as quickly as possible to giving them the naloxone, giving them rescue breaths, and calling for help if you can. So back before we had access to naloxone, people would try a lot of very creative things to try to get somebody to wake up out of an overdose. So things like, hitting them, kicking them, putting them in a cold shower, putting ice in their clothes, like all kinds of things. And I would never say anything bad about anybody who was doing the best thing that they knew how to do in a really scary situation, trying to save somebody's life. But it's really important that people understand that, the only things that are medically proven to help somebody survive the opioid overdose are getting naloxone in time and getting air in time. And anything else that we try is not going to help the situation and might end up making it worse. So the good news is that we don't have to do all that. We don't have to wail on them or drag them to the shower or give them a salt shot or anything like that. Give them the naloxone, give them rescue breaths. And those are the things that are going to give them a fighting chance. So you want to give them the first dose as quickly as possible so it has a chance to start working. So with the intramuscular, you're going to open up your pack. Inside it, you have 2 bottles of naloxone and 2 big intramuscular syringes, as well as instructions. So the bottles look like this. 1 bottle is 1 dose. You can see there's that much liquid in it. You don't have to measure it. You're just going to drop all the liquid in the bottle into the syringe. So you'd pop the orange cap on the top off. There's a gray seal underneath it. I'm going to put the bottle down somewhere steady, like the floor of the table. You want to open up one of your big giant muscle needles that's in the kit, take it out of the package, take the cap off. You're going to pierce that gray seal on the top of the bottle with the tip of the needle and flip the whole thing upside down. So you can use the plunger of the needle to draw back all the liquid in the bottle into the barrel of the syringe. So if you end up drawing a little bit of air up with it, that's okay. It's going in a muscle, not in a vein, so that's not going to hurt the person. Just focus on getting as much of the liquid as you can from the bottle into the barrel of the syringe. And then you're going to inject the person in a big muscle. So you can do their upper arm, their thigh, or their butt, whatever's easiest to get to. Just poke straight in the muscle and inject all the liquid in. The needle in the kit is really long, like 1 inch, 1.5 inches. So you could, if you had to, you could go straight through my sweatshirt and you would still reach the muscle just fine. So if it's hard to get somebody's clothes off, you can just go through if you need to. So just focus on getting that first dose into the muscle. It takes it a few minutes for it to get to the brain receptors and start to work. So give that first dose, and you're going to wait 2 or 3 minutes. If there's no change after 2 or 3 minutes, the person is not starting to wake up and their breathing is not coming back and their color is not coming back. You have a second bottle and a second syringe in the same kit. You would just do the same process, draw it up, inject it in a big muscle. Sometimes 1 dose is enough. Sometimes it takes more than 1. Sometimes it takes more than 2. It all just depends on a lot of factors. In the meantime, though, so you've given that first dose, you're waiting those 2 or 3 minutes to see if it starts to work. In the meantime, what you want to do is assess the person's breathing. So the person is not breathing at all, or their breathing is very slow or shallow, like less than 1 breath every 5 seconds. You want to go ahead and give them rescue breaths. And that's going to help pull them through until the naloxone starts to work and they can breathe on their own again. So this is just the mouth-to-mouth part of CPR. So, in regular emergency situations, they're saying move away from doing the mouth-to-mouth, do compression-only CPR. The exception to that is opioid overdose, because what is being affected first is the person's breathing. So they're saying focus on doing the rescue breaths, don't worry about the compressions. So you want to get the person to lay flat as best you can. You want to make sure there's nothing inside their mouth that they could inhale and choke on, like, food or gum or anything like that. So you can just take a couple of fingers and swipe through their mouth. Then you want to straighten out the path that the air goes through. So tilt their chin up, pinch their nose closed. And that just helps the air go through the windpipe and then keeps it from escaping out their nose. Tilt their chin up, pinch their nose closed, put your mouth over their mouth to get a good seal. Give them 2 slow breaths, breathe for yourself, give them another slow breath, breathe for yourself. Keep doing that, giving them about 1 breath every 5 seconds until they're able to breathe on their own again or until help arrives. And what you can do while you're giving them the breaths, you can kind of look down and make sure you see their chest rising a little bit, and that tells you the air is getting where it needs to go. If you see their stomach rising, you're not getting it into their lungs, so you want to make sure you readjust, make sure their windpipe is straight and you got a good seal over their mouth, and try again. So even if you don't have naloxone on hand, I've heard many stories of situations for people where with somebody who was overdosing, they called for help and they gave them rescue breaths until the EMS got there, and that was enough to get the person through. So that's something people can do in any situation. Even if you're unprepared, you can always give the rescue breaths if the person needs it. So giving them the first dose, giving them the rescue breaths if you need to, wait in those 2 or 3 minutes. If you have to leave them alone at any point in the process, if you have to, run to the next room to get your naloxone or to call for help or something, you want to make sure you put them in the recovery position. So just roll them on their side. You want to pull one arm up so that you can rest their head sort of braced on it so that their mouth is facing down. And that way, if they vomit, the vomit will drain out and they won't inhale it and asphyxiate. The third thing you can do besides giving the naloxone and giving the rescue breaths is, of course, call for help. And so we already talked a little bit about the Good Samaritan law. So it's important for folks to know the protections that they do and they don't have in that situation, so they kind of know what to anticipate and be prepared for. When you call 911, you don't need to say that the person is overdosing. If you don't want to, you can just describe what's happening. You can say, I'm with somebody who's not responding or not breathing. You want to give clear information about, where they are, so that where you are, so that EMS can find you and things like that. But you don't need to go into specifics about the situation if you don't want to. And so with the nasal version, it's the exact same process, but instead of the medicine being absorbed through the person's muscle, it's absorbed through the mucous membrane in their nose. So your kit has 2 nasal sprays that look like this. So you don't need to assemble anything. Just peel off the back, take it out of the package, insert the tip of the nozzle at the person's nose, press the plunger, and spray all that liquid up one nostril. So same process you give them the first spray. You want to wait 2 or 3 minutes to see if it's working. If there's no change after 2 or 3 minutes, go ahead and give the second spray. In the meantime, assess their breathing, give them rescue breaths if you need to, call for help if you can, put them in the recovery position if you have to walk away from them at any point. So if there's a couple people on site, you can always divvy up these tasks. One person can be in charge of administering the naloxone, one person can be giving rescue breaths, one person can be on the phone. But if it's just you, you can completely do all of those things. So you want to give that first dose as soon as possible. And then in that 2 or 3 minutes, you want to start the rescue breaths. You can get EMS on the line on speaker, and in between those 5-second breaks of giving rescue breaths, you can prepare and give the next dose of naloxone if you need to. Any questions so far about that whole process?
Yes. Can you show me again how you did the arm if they going up or something? You said the recovery position.
Yeah, so that is hard to do. I'm used to in-person trainings where I would just physically get on the floor and show you. But basically they're lying on their side on the floor, and you're rolling them onto their side, and then you're kind of pulling their arm up so it's kind of like a pillow so that their head is resting on their arm. And that way their mouth is facing down. Does that make sense?
Does it matter if it's on the left or the right side, or it don't matter?
It does not matter, yeah, as long as they're on their side and their mouth is facing down. And you can also kind of pull their top leg over so their knee is kind of braced on the floor, and that'll help keep them from rolling back.
Thank you.
You're very welcome. Thank you. Any other questions? All right, so let me get back to sharing my screen. Okay. And I don't think we talked about, so yeah, so what you might see. So if you're with somebody and you're trying to assess if they're overdosing or not, some of the visible signs that you might see are, their breathing being very slow or shallow or erratic. And sometimes you might hear like a gasping or a snoring or a gurgling sound. That's called agonal breathing. Their skin, depending on your skin tone, it'll start to turn like grayish or bluish. Sometimes their skin feels very pale or clammy. Sometimes you might not see any of those visible signs, and the person might just look like they're sleeping or they're nodding off. So the number one sign is really that they're not able to respond. So if you're shaking them, calling their name, if you try the sternum rub and they're not responding to that, that's the point where you'd want to initiate the steps. So when the person wakes up, so we talked about what the naloxone is doing. It's swiping the opioids off the brain receptors. So that means if somebody who uses opioids every day, having the opioids knocked off of the brain receptors puts you into withdrawal. So people can be experiencing precipitated withdrawal symptoms when they wake up. So that's a very unpleasant physiological feeling. It's not going to last very long. So the naloxone stays on the brain receptors for about 30 to 90 minutes. Once it wears off, there's still typically opioids in your system that will reattach to the brain receptors. So that feeling of sickness is going to go away again on its own pretty soon. The risk is if the person has enough opioids still in their system, once they reattach to the brain receptors and resaturate them, there's the risk that the process could start over again. They could slip back into the overdose and become unresponsive again. So that's rare, but it does happen. So it's really important that even if the person is revived and they're okay and they're walking around and they're lucid, that they're, somebody continues to kind of check on them and monitor them for a few hours after the overdose. So ideally they go to the hospital and get checked out. Even if they choose not to go to the hospital, they should be in a situation where somebody can keep an eye on them and they shouldn't be alone for a couple of hours. So we talked about calling 911. We talked about the Good Samaritan law and what it protects us for and does not protect us for. So I also wanted to talk about stimulant overdose because that's a little bit different than opioid overdose and its mechanism in the body and how we respond to it. So stimulants are, things like methamphetamine, cocaine, crack, prescription stimulants like Ritalin or Adderall. So we talked about with opioid overdose, how, what's happening is your respiratory system is being depressed, your breathing is slowing and then stopping, your heart rate is slowing, your blood pressure is dropping, your body temperature is dropping. Basically with stimulant overdose, the opposite of that is happening. So your heart rate is increasing, your blood pressure is rising, your body temperature is rising. And what can happen is you can sort of pass a threshold of that where you have a negative health consequence like a heart attack or a seizure or a stroke. So when somebody has a stimulant overdose, that's typically what is happening is a heart attack or a seizure or a stroke. So a lot of people will call stimulant overdose overamping to distinguish it from overdosing on something like an opioid that's a downer. So with overamping, unfortunately, there's no magical antidote like naloxone that will stop it while it's happening. Once you're having a heart attack, you're having a heart attack. Once you're having a stroke, you're having a stroke. So there's nothing you can give somebody at that moment that will halt the process in the same way that naloxone will restore a person's breathing in an opioid overdose. So the best thing to do for somebody in that situation is, to call 911 to give them CPR as needed. But the other thing to keep in mind about stimulant overdose is that it's not dose dependent. So that's a fancy way of saying like the amount of the drug that I take matters in terms of whether or not I overdose, but other things matter also. So with stimulants, I could be somebody who uses cocaine every day and I never have any sort of negative consequence from it health-wise. And then one day I use the same amount that I always use, and then I overamp and I have some sort of a negative health consequence like a heart attack or a seizure or a stroke. And that is often because, so the amount of the drug matters, but equally important is just our general physical state. So a lot of times when folks are using stimulants, they can, we can get into situations where we're not sleeping for a long time, we're not, eating regularly, we're not staying hydrated, we can be in really stressful situations. Like all these things can kind of wear down your body's defenses and make it more likely that you'll overamp. And the opposite of that is also true. So just taking basic care of yourself can be really protective. So when people are using stimulants, sleeping as much as they can, drinking water, eating, like those things can help reduce that risk of overamping. And so overamping, it can be those really serious physical things like heart attacks or seizures or strokes that you want to seek medical attention for right away. But it can also be, people can experience like psychological overamping symptoms. So things like anxiety, paranoia, hallucinations, psychosis, things that can be really scary and really difficult for the person who's experiencing them and for the people around them. So sometimes with those things, it can be a little bit harder to tell, like, when is it best to call 911 and get them to a hospital, and when is it something that can be managed, in a home environment kind of thing. So sort of the rule is if it's something like a seizure or a stroke or a heart attack or like clinical overheating where somebody's body temperature is like over 104, absolutely calling 911 is the thing to do, getting the medical help as soon as possible. If somebody is like just experiencing like some of the sort of borderline, like they're feeling anxious, their heart is racing, they're starting to feel paranoid, things like that. Sometimes those symptoms can be managed if they're in like a calm, safe environment. So encouraging folks to do things like, eat a snack, drink a water, be somewhere around people that they trust, grounding things, calming down, just, basic things that help people who are in sort of a heightened state in general can help sort of walk them down so that they don't tip over that point where they're really needing medical help. Does anybody have any questions about the stimulant overdose overamping stuff? Cool. So I also wanted to talk about a little bit about,
Lofton,
yes.
Lofton, this is Kay. Sorry, it took me a while.
Oh, hey, Kay.
Hi. It took me a while to figure out how to make the machine work. So one of the other things that I think we've noticed in the last couple of years is that if for some reason we get some fentanyl into the stimulants that we're using, it may be that we don't know it. And if you are unsure and you see all of these symptoms and it looks like somebody also is not breathing the way you would think they should be, it does not hurt to give them the Narcan as well. And this again is one of these, you can't do any harm, but you could possibly do some good. So whereas we used to always say, if, you're using, cocaine or meth or something, don't bother, don't waste your precious Narcan. Whereas today it may be, just on a point of being extra cautious. Go ahead and give it if you think there's any possibility that what they're using could have the fentanyl in it. And polypharmacy now is so common. And even if that's not what we're trying to do, it may have happened anyway. So if in doubt, go ahead and use the Narcan as well.
That's such a good point, Kate. Thank you. Yes. Because people, a lot of times people use more than one drug. You might not necessarily know what somebody's chosen to use, but as well as Kate pointed out, a lot of times things these days that are not opioids can be contaminated with fentanyl. So sometimes somebody might be using something like cocaine and not have any intent to use an opioid, but there is an opioid present. So you're absolutely right. If you're in a situation where somebody's overdosing, you're not quite sure what type of overdose it is or what they took, and you have naloxone, it never ever hurts to go ahead and administer that because it will either help or do nothing. So that is a really good point. I want to talk a little bit about preventing overdose. So using the sort of drug set and setting framework. So that talks about sort of lowering overdose risk in 3 different domains. So thinking about the overdose risks that are presented by the drug, and then also like lowering your risk in terms of your mindset or your physical and mental state, and then the setting that you're in, like where you physically are. So in terms of the drug, so things like drug checking that we've talked about before. So empowering people to have more information about what they're actually using, which is difficult with an illicit drug supply. So things like fentanyl test strips, things like the mail-in drug checking program or on-site drug checking machines that help people be able to manage risk by having more information, our overdose prevention tools. Start low, go slow. So thinking about, you can always add to what you put in your body, but you can't take back what's already in there. So, starting out with, just a little bit and seeing how it feels, and then gradually increasing that, similar to, the tester shot idea that we were talking about before, that also applies. Thinking about the route of administration. So again, it is safer to smoke or to snort or to eat or to boof any drug than to inject it. So thinking about if somebody is, using a drug, it's helpful to not start injecting at all, or if somebody is injecting, to think about scaling back and using a different route of administration instead, either some of the time or all of the time, to help reduce the risk of overdose. So in terms of set and setting, thinking about things like the person's access to medications for opioid use disorder. So being on methadone and buprenorphine, those are long-term overdose prevention tools. They, being on these medications increases people's life expectancy and cuts their risk of overdose and death by for other reasons as well. I think in half is what the research shows. So they're very, very effective long-term overdose prevention tools. Thinking about, never using alone, having people that you trust to be around you while you're using, who know how to use naloxone, who you trust to be able to help you and call 911 if needed. Doing things to keep your general sort of physical well-being up. So staying hydrated, fed, rested, safe. A huge one is knowing your tolerance. So especially with opioids, anytime somebody's been using for a while and has developed a tolerance and then stops using, your body loses that tolerance really quickly. So some situations where that happens a lot is if somebody has been in jail or been in detox and they've stopped using for a period of days or weeks or months, and then they come home and they start using again, using even half of what might have been my regular thing that I used every day before when I had a tolerance. Using that when I don't have a tolerance can be lethal. So making sure people are aware of their changes of tolerance and how that affects their overdose risk. And that if they are using after a period of abstinence, that they have naloxone, that they're with people, that they're going slow, and all of these other things. Also just knowing your health risks. So, if you have untreated cardiovascular issues like hypertension or things like that, that can increase your risk of stimulant overdose. If you have, asthma or COPD or something like that, that affects your breathing, that can increase your risk of opioid overdose. Like, helping people to sort of understand and manage their general health and any conditions that they're dealing with can help people reduce their risk of overdose as well. So the last thing that I wanted to go over with y'all together is this wonderful document from Edith Springer, who is one of the sort of founding parents of harm reduction. So she put this document together in 1991, and then it was kind of updated and expanded by Mona Bennett, who's another harm reduction leader from Atlanta, in 2016. So these are a set of kind of like things to keep in mind, or attitudes, or sort of like reminders for folks who are practicing harm reduction. So these I find really helpful, even just as an individual, like, practicing harm reduction in my own life, but also especially when I'm working with people in the community, as sort of grounding reminders of what's helpful, sort of how it's helpful to be in relationship and in community with people. So if it's all right with y'all, I would like us to kind of read these together. Oh, I have gone all the way. Okay. So if anybody who feels comfortable reading wants to just chime in and read a bullet point out loud, we can move through them together at whatever pace we want to. I'll read the first one and I'll pass it off. So the first one is: show client unconditional regard and caring, acknowledge his or her intrinsic worth and dignity.
Be a real person, let the client see you as you really are. Blank screens are for movie theaters.
Don't get caught up in the client's urgency. Take your time, practice mindfulness.
Be non-judgmental toward the behaviors of the client.
Be consistent with setting limits, control oneself, not the client.
Empower the client.
Work through one's behaviors or enabling when it is positive, when it is negative.
We are not responsible for rescuing the client who is responsible for his or her own life. We are responsible for the intervention process. The client is responsible for the outcome. Trust the client's strength and ability.
Never take away defenses until alternatives are developed. Introduce new coping strategies and shore up those used previously.
Avoid the expert trap, especially if you aren't one. Use the client as a consultant and a collaborator. Act out of a place of humility.
Explore one's own values about drugs, drug users, and sex workers, homelessness, and the homeless.
Be mindful of the stage of change. Set the table, provide options, non-judgmental and non-coercively. Any reduction in harm is a step in the right direction.
Reinforcement is more effective than punishment. Use incentives when available.
Use supervision to process emotional responses and attitudes.
The agenda for the change belongs to the client. The worker facilitates rather than implements the agenda.
Consider the client's relationship with drugs and sex, the positives and the negatives, rather than the judging the use itself. Focus on behaviors.
Quality of life and well-being are the criteria for measuring success, not reduction in the consumption of drugs.
Thank you all so much for doing that. It's so nice to hear so many familiar voices. I heard LA, I heard Abana, I heard lots of people, Helen, lots of people. So it's nice to know there's so many friends on the call. That is the end of what I had prepared to share with y'all. So what questions or, what things did y'all want to learn about today that were not addressed? Or just general questions or comments for me or for the group or anything on y'all's mind?
Lofton, this is Kay again.
Hey, Kay.
The only thing I would suggest is you tell us specifically how to find you and the other harm reduction team in Durham and in the area.
Yes, absolutely. So there was a slide on that earlier. So when we send the slides out, you'll see it. It has our hours and our phone number and stuff. And then I think when we send the slides out, I can also ask Lloyd to send the flyer that has our information for NCHRC's SSP. And then the Durham Health Department SSP, there's probably people on here who know more specifically than I do, but you can just walk in and go to, I think it's Clinic 2, and talk to like the pharmacy team there, and they have naloxone and syringe supplies and things like that available on site at the health department whenever they're open. Oh, and I see, Michael, you put the information for Jubilee Home as well in the chat, which is great. Yes, Jubilee are a wonderful.
Yeah,
resource.
just for, I see we got like 52 participants in here. So I just wanted to say, Lofton, from me to you, you did a really good presentation. I attended a training earlier in the week, and it was nowhere near as informative as this one was. I'm not going to lie to you. At the beginning of this, when I started reading some of the slides, I was kind of like standoffish, and I've seen you guys out there before. A little bit about myself. I just recently graduated the TROSA program. I actually used to be here as a client about 2.5 years ago. So I'm kind of on the opposite end of the fence now. And so I've had some very active years in addiction. And what really sealed the deal for me was on the last slide. And like I mean, and it was literally the nail in the coffin. On the last slide, there was a connotation on there that said quality of life and well-being is the objective and the goal, not the reduction of drug use. Because there was a small part of me, I'm like, I can't help but feel that this might be enabling, but with everything that this offers as a consensus, I've absolutely changed my stance on that. So just really good presentation, and thank you. Happy to be here. And again, Jubilee's contact information is out there for any and every participant that is here. It's all about networking. So the more we know, the more we can help folks.
Thank you, Michael. That is so great to hear, and I really appreciate you candidly sharing your perspective. Absolutely. I mean, I think there's a lot of, especially when it's something that we haven't like heard sort of the language around before, it can be a little bit like startling or shocking to kind of hear about people saying, but I think that you really have identified sort of the core of it. It's like the idea is increasing people's health and well-being. And for some people, that means stopping the drug use altogether. For some people, they're not at that place, or maybe they may never be at that place, but harm reduction is about opening up.
Right.
There's things we can do in that moment, even if you're not in that place, that improve the health and well-being. Absolutely. That's a key part of it. I'm glad that you kind of pulled that out and talked about it.
One of the cool things that we've done in harm reduction is, we've always said meeting people where they are in their life. But over time, we've begun to add one tiny little phrase after that, but not leaving them where they are. We are there simply to look for mechanisms to find, as Lofton and Michael were saying, their well-being, that they are, in a better place than when we met them. But we are there walking with them, not shoving them forward.
Absolutely. It's about, building that supportive relationship, hopefully over time. Yeah.
Any suggestions for starting these conversations with clients, especially if they aren't seeking services directly from you, or these aren't people that you don't have rapport with necessarily, and how to kind of just begin that piece of it?
That's such a good question, Rebecca. I really appreciate that. Because it's, yeah, especially if it's, you know, you're working with somebody for the first time, and especially like in your situation, working with housing. And I mean, people as people who use drugs, we are so used to, like, in situations where we're seeking, you know, housing support or healthcare or anything like that, to having situations where the door is closed because of drug use. So that can make it really difficult, to be honest, and to have these conversations, because we're worried about losing access to whatever the services that we're trying to get. So I think, you know, as providers and as community members, just, you know, being mindful of, you know, the language that we use and the questions that we ask, and just trying to, like, you know, not in, I'm trying to think of like specific examples of it, but like, I mean, just trying to indicate by, you know, whatever way makes sense in the relationship and the conversation and the context, trying to indicate that your goal is, you know, for example, for you, you know, your goal is helping people, you know, get and maintain safe housing, and that that goal is not mutually exclusive with whatever else that they're dealing with, whether that is drug use or mental health stuff or physical health stuff or whatever. There's lots of, like, and I think some of those, like, small sort of language and cultural changes that we talked about at the beginning. So thinking about kind of using neutral language and things like that can be really helpful in those conversations. So instead of, you know, calling people addicts, you know, choosing other language, like saying, you know, substance use disorder, or people who use drugs, or things like that are more neutral. Little things like that can make a big difference. But that is difficult. Absolutely. It's a situation where there's a lot of kind of accrual over time of people's experiences interacting with systems that have sort of primed people to not feel comfortable discussing that kind of thing in that situation, in my experience.
Thank you. That's helpful.
I think even just like if you're offering, so, you know, sorry, I just thinking, like, if you're offering like other resources. So if you know, if you know somebody does use drugs, if you're offering, you know, detox or medication or something, just having harm reduction resources on that kind of menu at the same time, that can help with having those conversations. So like having a variety of options to offer people, rather than just saying like, oh, you should go to detox, like recognizing that there's other paths as well. And go ahead, I cut somebody off.
Lofton, that was just me again. The two of us often think on the same wavelength. One of the things that I've found to be a little bit helpful is these information sheets that are in the resources for people who use drugs that have been put out in a couple of different ways. If you have that document, you might simply open it up to the page that shows where we are and say, did you know that there are all of these other services available? And, if, getting food is a problem, or if you are using and you want help with making it safer, or you want to find some way to get treatment or whatever, these are a bunch of resources that are available right here. And would you like a copy of this page? And then use that, like a copy of it, or, are there any of these places that you have questions about? So that's just a nice, safe opening saying, I'm not saying that you are in need of any of these, but these are the really cool resources we have around here. And, would these be helpful?
Absolutely. And sometimes if somebody is like hesitant to disclose or sort of discuss their own drug use, it can also be helpful to kind of frame it as like, these are resources you should know about to help the people around you. Because lots of people access harm reduction programs who aren't necessarily using, who are picking up naloxone because they're worried about, their partner that they live with, or, their people, in their campsite. Maybe they don't necessarily use what people around them do, or they're picking up supplies for their friends or things like that. So kind of opening that up and and recognizing this is like a resource that everybody should be aware of, and everybody probably has somebody in their life that's impacted by this stuff. So rather than being about like, do you or do you not inject drugs, have it be like, hey, this is something we should all know about.
That's really smart. Thank you both.
I would say just to piggyback off of what Kay said, if it's an individual that you don't necessarily have rapport established with, you know, a way to form a little bit of camaraderie is just to let them know that you're just there to help, and you simply put out what services that you do have access to, and you assure that person that if the help that they may be trying to seek, you cannot provide, you know, your job is to serve as a conduit to align them to other people that may potentially be able to provide the kind of help or assistance that they might be seeking. Need that be substance abuse, housing, shelter, outreach programs for health, mental wellness. Again, as Lofton says before, a lot of people that's stigmatized. Somebody's quick fix always is, oh, send them to RI or, you know, the Durham Recovery Response Center, or go to detox, Wakebrook, you know, things like that. There's multiple ways to offer assistance to somebody, whether there is or is not, you know, rapport established, or if you do not know that person. All we can really do as people that are in the line of work that we're in, you know, if everybody's actively participating in the Zoom meeting, we're doing what we do with the objective to help people or to alleviate suffering of some kind. So I'd say just to let people know that we're there for them in whatever aspect we can be. And it's our job is to assess how we can help them by determining, you know, specifically what they may need. It's just a conversation that has to be had. You know, it's as simple as that.
I'll chime in. This is Lloyd. Good afternoon, everyone. Just, I think that one of those first statements about approaching people non-judgmentally, I think can be a challenge for us in the work. Certainly a challenge for me many times. But I think that, as Michael said, just to let people know that we're there for them, that we're not there to judge them, but we're there to provide support, there to not make decisions for them, because they are responsible for their decisions, but we want to try to do the best we can to offer them support, offer them options for their lives, and if they're, you know, would like to take advantage of resources, there are resources in the community that can help them in whatever ways they would like to receive help.
And this big group of wonderful people is such a great example of that. Like, all of y'all are doing different types of work, but it's all, you know, it's all about supporting people. So thank you, each of you, for all that you're doing every day. Any other final thoughts, questions, wisdom from anybody?
I will just chime in with a word of, more than a word, Lofton, a round of applause, and thanks so much for leading this discussion and sharing these resources and sharing your wisdom about a very difficult topic, about a really a deadly serious situation in Durham and throughout our state and nation, really, in these times. So really appreciate the information that you've shared. Thanks so much, Kay, as well, and others who contributed to the discussion today. Thanks to everybody. We recorded this session. I will be working with our team here at the city's Community Development Department to post the video in the training so that it can be available to people in the broader community as well. So really appreciate it, Lofton, very much. Thank you.
Thank you, Lloyd, for organizing it. I really appreciate it. And
didn't do a whole lot. You put it on your calendar, and we spread the word and people come. So thanks very much.
Absolutely. And if I can be of support to any of y'all, please feel free to reach out. I will put my email real quick in the chat. And I'm also, you can Google me. There aren't very many Loftons, so you'll probably find me pretty easily. All right, y'all. Well, have a wonderful rest of your afternoon and be safe. And thank you for being here and for being you.
Thank you, Lofton. Bye-bye.
Thank you.